Welcome to Health and Harmony Beyond the Teeth, where we dive into all subjects that will help you become healthier and happier. As a dentist, I believe dentistry is more than just teeth, so I created this show to focus on overall health. We will hear from leading experts about eating better, exercising better, breathing better, and sleeping better. We want to help you create harmony in your life so you can live your life to the fullest. We want you to thrive. Hello, I'm Dr. Stewart. Our podcast today is a recording of a webinar that I did for a group of mothers several weeks ago. This group of mothers, they meet regularly. They're pursuing health interests that are more holistic for not only for themselves, but for their children and for their entire families. I think you'll find this very informative and I hope you enjoy it. So you all have children. I'm assuming everybody on this call has children. And if you don't, maybe you have grandchildren. Well, if you have grandchildren, you have children too, but maybe they're grown. Anyway, all of these symptoms you see here, I'm not going to read them all, but just read through them for 10 or 15 seconds here. All of these things that you see here can have an oral breathing component and be directly related to that. And so these are things that we look at when we see children. We look at these signs and symptoms and we can identify perhaps why they're suffering from these things. This is a very common issue with kids, ADD and ADHD. What has happened? Why wasn't this a problem 50 years ago? There were hyperactive kids when I went to elementary school, but there wasn't. It doesn't seem to be nearly as prevalent as it is now, or maybe it was, and it just wasn't being. It wasn't being caught. It wasn't being diagnosed. And again, ADD and ADHD are just a set of symptoms, and that they lump them all together and call it ADD. I think we have discovered the root cause for the majority of ADD issues. Asthma, another chronic condition that can be that's affected by breathing and sleep. Your child's bedwetting, that's not normal. So we see these things going on. Kids that do poorly in school, that can be a sleep breathing issue that's keeping them from being their best. Hyperactivity, as I mentioned before, or even aggressive behavior in children. I don't think children are naturally aggressive, but if they're not sleeping well, if they're not breathing well, they're going to be in a state of hyper anxiety, and that might make them more aggressive. That might be how they take out their energy. If your child is grinding their teeth, you worry about that. I don't want any of you to worry about these things. I want you to know that I want you to be concerned, and I want you to know that there's a solution. So hopefully, me going through this, you may be identifying your own children or your grandchildren or your friends' children. When they're sleeping, is their mouth open? That's not normal. It's not. I mean, anybody at any instance in time might have their mouth open when they sleep. If this is a chronic way that your child sleeps, that's an area to be concerned about. So here's what chronic mouth breathing. Oh, someone just logged in here. Let me admit them. Okay, that's Allie. Welcome, Allie. This is what chronic mouth breathing will do. This is a face on the left, nasal breathing with proper jaw sizes, proper breathing through the nose, and over a period of time, the way we breathe and the way our tongue functions affects our face. And this is an example of what happens when we mouth breathe. Tired eyes, recessed chin, open mouth, poor posture. That is very common. As a matter of fact, I can see people in the grocery store or children playing on the playground, and I can tell the ones that mouth breathe and the ones that don't from just looking at their faces. Now, that's an exaggeration, but it really isn't. I see a lot of people that look that way. So when we breathe through our nose, we have a healthy respiratory system. It's calm breathing and it's efficient. When we breathe through the mouth, It affects the digestive system. It's a stressful type of breathing. It's a very shallow type of breathing. It's very inefficient. So a mouth breather tends to be more high strung, more anxious, high anxiety. They have to be on the go all the time because they don't have that calm, deep nasal breathing. So childhood obesity is a problem as well. And when we're not sleeping well, our cortisol levels stay very high, and it's really almost impossible to lose weight. So a lot of childhood obesity is from not being able to breathe and sleep well. And so really the start of everything is breathing and sleeping. We cannot be healthy if we don't breathe well and we don't sleep well. There's just no ifs, ands, or buts about that. We can live without food for a month. We can live without water for about a week, but we can't live without breathing for more than just a few minutes. And sleeping is the way our brain computer resets every single day. Night sweats, that's also a sign of a child with a sleep related breathing disorder and a poor airway. So we want our children and adults, for that matter, remember Dairy Queen Sunday. Their sleeping should be dry. They shouldn't be drooling out of their mouth because their mouth should be closed. They shouldn't be wetting the bed. It should be dry. They should be quiet. You should not be able to hear your child breathe, or your husband, or your spouse, for that matter. Breathing and snoring, or heavy breathing, loud breathing, snoring, those are not normal. So breathing should be quiet, and the person should be still. Doesn't mean you're in the same position all night, but no thrashing around. And you've probably all, if not with your own children, have seen, heard friends or other parents talk about how their child just is all over the bed and their sheets are, twisted and contorted in the morning because they're just all over the bed. Those are all signs of an airway issue. Um, so there shouldn't be any moisture, no wetness, no drooling, no peeing in the bed. Noisy breathing should not be, or restless type sleep is, those are all no-nos. So if you want to know if your child is doing this, go in after they go to bed, go in 1 hour for 3 hours in a row and watch them for 5 to 10 minutes and observe what you see. If you just go in and peek every now and then, you're not really going to get a good idea. But if you'll sit and watch them for 5 to 10 minutes for 3 hours in a row and do that for 3 or 4 or 5 nights in a row, document what you see and you'll start seeing a pattern. Are they dry, quiet, and still, or are they wet, noisy, and restless? So a sleep disordered breathing in a child will eventually lead to sleep apnea. And sleep apnea can be a very serious chronic disease. So is having ADHD an advantage? I actually read an article the other day about how ADHD is actually advantageous for children. And I wanted to contact the author and the publisher of this article and just say, you don't know what you're saying. ADHD is not, it is a condition that's derived from a series of symptoms that are all related to a chronic breathing issue. So ADHD is not an advantage. If your child has ADHD, do not get them on medications. Have their airway and breathing checked because that most likely is the cause. So we are we have our practice. Dr. Corridor and I both started out seeing adults only and being TMJ and bite specialists and doing adult dentistry only. And about 10 years ago, we started realizing that these TMJ issues and all these malocclusions and worn and crooked and crowded teeth all were related in that all of these patients had sleep disorders. And so we get to see the effects of childhood, chronic childhood breathing issues. We were seeing those 20, 30 years down the road. So about 2015, 16, we thought, you know what? Why don't we start? We don't want it to be pediatric dentists, but we want to be able to make a difference in these children. So we started talking to pediatric dentists, and they really weren't. I don't say they weren't on board with this, but they have their systems and they have their ways of doing things, and they really didn't want to listen. So we just decided, heck, we're going to start treating these children. We're going to start treating, helping their jaws grow so they can breathe better, and they're going to be a lot healthier. So that's how we got into treating children. And so now we treat children. The earlier we get them, the easier it is to get them into a really good, healthy sleep and breathing pattern. Um, so we get to adult sleep apnea because of childhood sleep and disordered breathing. And so crowding is the most common of malocclusions. And so if you look at your children's teeth, if they're not in a row with spaces in between them, if they're leaning in and their teeth stacked up in front and behind each other, that means their jaws are too small. There's no ifs, ands, or buts about it. Before the Industrial Revolution, there was literally no teeth crowding at all. It was all the jaws were big enough to house all the teeth. And I'll get to that in just a little bit. So the causes of crowded and malocclusion are improper dental arch form. Teeth haven't changed in sizes in the last 1,000 years, but jaw sizes have decreased dramatically since the Industrial Revolution, and now there's just not room for them. And so we end up getting crowded arches, malocclusions, and no room for the tongue. The tongue gets pushed back into the airway. So a proper dental arch would look something like this, not like that. Look something like this. So here's a good contrast. A nice healthy dental arch on the right, and a dental arch that is crowded, not enough room for teeth on the left. It's V-shaped, not U-shaped. Um, that looks like a Roman arch. That looks like a Gothic arch. And so other things that we see when we look at children, we see this venous pooling under the eye with that purple kind of bags under the eye. Even in children, we see this. And the reason why, if the maxilla, the upper jaw, doesn't grow properly, then the venous supply that drains right underneath the eye can't drain very well. And we see that venous pooling, those bags under the eyes and the darkness under the eyes. So this is not the cause of crowding. Too many premolars, or too many lower incisors, or too many teeth, or their head is too small, or their teeth are too big. Those are not the reasons for crowding. We need all of our teeth. Our jaws should accommodate 32 teeth easily. Now, there are exceptions. Here's an anomaly. This occurs in about one in every 5 million patients, where you've got all these extra teeth. That's not what I'm talking about. I'm talking about someone born with 32 teeth buds. All of those teeth should be able to erupt in in a non-crowded manner. So if we put the pieces together, we see that improper arch form and width are the result of inadequate development of the upper and lower jaws, and an underdeveloped upper jaw causes crowding, and an underdeveloped upper jaw will have an adverse effect on the lower jaw, because the lower jaw has to fit inside the upper jaw. So the upper jaw really is where all of this um, we don't. I'm going to say we concentrate on the upper jaw, but the upper jaw development is a key into proper growth and proper cranial facial development and proper breathing. So normal growth is wide. We grow wide, our jaw goes forward and down. Abnormal growth is any combination of narrowed jaws, backward growth, and downward growth. And the most abnormal growth is underdevelopment of the jaws. So here's a normal 5-year-old. This is a picture of health in a 5-year-old. We see spaces between the teeth. When this child bites down, we can see half of the lower teeth. The upper teeth don't, or the jaw doesn't completely go up inside the upper jaw. We can actually see the lower teeth as well. The midlines are lined up pretty good. The teeth aren't crowded. We see a nice big airway here. We'll look at airway again in a moment. This is a normal 5-year-old. So this is really an endangered species. But this is what a normal 5-year-old, if they're breathing and their tongue is functioning correctly, they will turn into a normal 12-year-old. where we see things lined up really nice, no orthodontics necessary whatsoever in this case. So this endangered species, we don't see that often. We see a lot of things like you see here and here and here and here. These are all issues that have to do with jaw growth and tongue function or tongue dysfunction. So if the jaw grows properly and the tongue works properly, we have well developed jaws and we have well developed airways. And so, when we're looking at somebody, we're looking at is their jaw upper and lower or both underdeveloped, and what prevented their development? What causes it? Well, Dr. Corricini is an Italian anthropologist, and he wrote a book. I actually have a copy of this book. They're out of print now, but he is probably the foremost leader in forensic anthropologist studies. And he has 30 plus years of research, and he's the one that determined that once the Industrial Revolution came along, our diets changed dramatically. We started eating processed food. There was a lot more pollutants in the air, and the nutrients were out of our food. And literally one uh, generation after the Industrial Revolutions, jaws became much narrower, and we started seeing orthodontic crowding of the teeth. Before the Industrial Revolution, we never saw that in the studies of these skulls. And so a soft processed diet results in smaller body mass, less dense bone, small and weaker oral musculature, a narrow upper jaw, a smaller lower jaw, thinner bone, and small condyles, the ball and socket of our jaw, the TMJ, are smaller. And so the first generation after being exposed to processed food, the Industrial Revolution, 50% of jaws were smaller and had crowded teeth. By the second generation, it was 70%. By the third generation, 85%. By the fourth generation, 90%. And now, modern day, the vast majority of kids require some type of orthodontics because there's not enough room in their jaws for teeth. And the reason why is because we have, in dentistry, have focused so much on teeth, we're not looking at jaw development. In our practice, the teeth are the last things that we deal with because we want to set the foundation first. And so Dr. Corricini is the leader in this, and he's written over 70 research articles on this. So, in conclusion, breastfeeding our children for as long as we can is very beneficial because breastfeeding creates a musculature response that is conducive to jaw growth. Bottle feeding does not have that. Bottle feeding is more like feeding the child with a fire hydrant. And I realize that, bottle feeding is a necessity at some times, but we need to. I mean, this is easy for me to say, this man here that's never birthed a child, but I'm just going by what we know as a fact and what we know medically, that breastfeeding will set that child up for success in developing the musculature, which then will develop the jaws. When the tongue posture swallows on a nipple, it's different than on a bottle. And so this begs the next question: what are the results of having an undeveloped upper and lower jaw? So if we look at the face, the vast majority of the face is made up of this upper jaw, or called the maxilla. And the maxilla, as you can see in this picture, if it's underdeveloped, the tongue, the soft palate, everything will have less room, and it can only go one way, and that's back into this colored area that we call the airway. So the nasal passages, the air comes through the nasal passages, down behind the soft palate, which you see here, down behind the tongue and into the lungs. If these tissues, because there's not enough room in the mouth, are being pushed back into this airway, we're going to have a child that sleeps with his mouth open, his or her mouth open, and that has poor respiration, and they're going to be prone to asthma. They're going to be prone to chronic diseases, sinus infections, colds, the flu, anything, because that takes away from our natural um, uh, line of defense is our skin and our and nasal breathing, because nasal breathing takes out many of the pathogens in the air. But if we're mouth breathing, we don't get any of that filtered air. And so a small jaw results in a mouth breather, which results in chronic disease. And so if you look at a skull from a prehistoric, this is a prehistoric uh, maxilla turned upside down, but you can see all the teeth are there. And these are the internal nasal passages, or the nostrils, internal nostrils. Look how big they are. And then this is a skull from the 1940s. Look how small, a very reduced airway from what we used to see. So this is a very healthy airway at age 10. And if you're on, hopefully most of you are on a computer. If you're on a phone, it's going to be hard to see this, but this dark area here, here's the nose. This dark area here, those are the nasal passages going past the sinuses, going past the soft palate right here and down into the lungs. See how big and wide that airway is, that darker area there? Look at a same 10-year-old, not the same 10-year-old, but look at another 10-year-old with underdeveloped jaws. Look how much skinnier and thinner this child's airway is than this child. There's a huge difference. This child, I could, just by looking at this x-ray, I would know that this child, for all intents and purposes, is very healthy and very well adjusted. And I could just start listing chronic issues that this child is suffering from at age 10. So sleep disordered breathing is mouth breathing, snoring, upper airway resistance syndrome, and it finally leads to sleep apnea. So a child starts mouth breathing. As they get older, mouth breathing turns into snoring. Some children snore. That turns into upper airway resistance syndrome, and then that eventually will lead to obstructive sleep apnea. The problem is that even back at mouth breathing, that's still something to be very concerned about, because if we're mouth breathing, we're not sleeping well. And if we're not sleeping well, our brain is not developing well. And if a 5-year-old's brain is not getting the proper sleep and the proper nutrition, that growth of that child is going to be affected. So again, I go back to breathing and sleeping are so very, very, very important for children. We want to increase nasal breathing, but so many have decreased nasal breathing. That leads to altered biochemistry and physiology. And the end result is sleep fragmentation or disruptive sleep. The reparative sleep cycle is disrupted every single night, and an unhealthy child will grow up to be an unhealthy adult. If they're not sleeping well when they're a child, they're going to be an unhealthy adult as well. So I want you to listen to this video. It's just a couple of minutes long of this Dr. Karen Bonnock. She's a PhD, and she published a research in 2012 that followed 11,000 kids for 6 years. So I would say that's a pretty darn good study with a lot of good information in it. So hopefully you can hear this.
Well, sleep disordered breathing is really a combination of symptoms, and it spans the continuum from snoring all the way up to obstructive sleep apnea. And a parent would recognize that if they observe that their child is habitually snoring, or apnea, which is really kind of small pauses in breathing during sleep. Like if you look at your child and he or she goes, during sleep, then you might want to check out that that child may potentially have an issue with apnea. Our study was published in Pediatrics. The central finding overall is that sleep disordered breathing is associated with a 50% increase in adverse neurobehavioral. What we found was that the worst outcomes were seen in the children with the worst symptoms. These are the children that had the highest levels of snoring, mouth breathing, and apnea, and those highest levels occurred at 30 months of age. After that, the symptom levels actually went down, but you still see adverse effects from this sleep disordered breathing all the way out to 7 years of age. Before this study, certainly we knew of a lot of the adverse effects in terms of behavior, growth, cognition. The difference with our studies, we studied lots of kids. We followed them for nearly 6 years, and these were the general population. The parents responded to mailed questionnaires about, among other things, the child's snoring, mouth breathing, and apnea. We used something called the Strengths and Difficulties Questionnaire, which is a 25-item questionnaire, which the 5 components include hyperactivity, peer relations, conduct issues, sort of like aggressiveness, emotional symptoms, which would include being anxious or withdrawn, as well as on the opposite end, pro-social behavior, which has to do with sharing and help. We use their responses about sleep disordered breathing to predict those behavioral outcomes then at 4 and 7 years of age as part of a large epidemiologic analysis. While it's difficult to say whether our study establishes cause and effect, the fact that we measured the symptoms and then went on to predict the outcomes later in epidemiology that there's a strong association. If the parent suspects that their child has sleep disordered breathing, they should raise it with their child's doctor.
So hopefully you could hear that, but a summation of that is that basically children with sleep-related breathing disorders had the same exact symptoms as kids with ADHD, and so there's a very, very strong correlation. Um, so I'm going to when we diagnose a child, we don't just look at them. We take very, very detailed records, and we do a sleep study when applicable. The best sleep study that we can give for a toddler or someone up to about 10 or 11 years old is just having the parent observe them and tell us what they see. Like I explained to you guys earlier, 10 minutes per hour, 3 hours in a row, 4 or 5 nights in a row, make notes, and then we get a really good idea of what the patient's sleep is like. So the measurement in general on a child when they turn 4 years old, we should be able to measure between those molars at 4, and that should be 30 millimeters. So if it's not 30 millimeters, we know that they're behind growth. And so basically, it's their age plus 24 millimeters. So someone else wants in. So if we have a 9-year-old and we're measuring 33, 34 millimeters, that's normal. We would like to see that. Unfortunately, we see far too many 8 or 9 years olds that are not even 30 millimeters in width. And so the good thing is at that age, it's very easy to affect their growth. Dr. Bogus, a very important study that came out. Any child age 4 who measures less than 28 millimeters has delayed development in their jaw. So you can ask your pediatrician or your pediatric dentist, rather, next time you go in, if your child, have them measure between their first molars. If they only have baby teeth, they would measure between the second baby molars. But if the 6-year molars are in, they would measure between the permanent molars, and that distance should be for a 4-year-old basically 24 plus their age. So if they're 4, it should be a minimum of 28. If they're 10, it should be a minimum of 34, and so on and so forth, up to age 18. At 18, our jaw should be fully developed at 40, 42, 44 millimeters in width. And again, that's a rare species. We don't see that a lot, but we can get people there. So again, this distance between the baby second molars should be a minimum of 28 millimeters in a 4-year-old. So just remember 24 plus the age of the child. We also we look at their jaw size. We look at their tongue. Do they have a tongue tie? Because a tongue tie can affect the position of the tongue and keep their jaw from developing. The tongue is the primary developer of the upper jaw, the tongue and diet and nutrition. So if the tongue, if a child has this is a grade 4 tongue tie, but even a grade 3 tongue tie that's not quite so obvious can affect the way a child's jaw grows. And so we're looking not only at jaw size, but we're looking at their tongue and their tongue function. Uh, the way the tongue function, it relates to jaw growth. It also relates to digestion in an infant. If there's a tongue or lip tie restriction, that could be keeping them from latching properly, which would affect digestion, which would affect growth, and which eventually would affect jaw development. So my wife, Dr. Corridor, she specializes in assessing infants and young toddlers for tongue and lip ties. And if we get a 2 or 3 year old in that's got a tongue tie, we get their tongue released and get that tongue working properly again with the help of a myofunctional therapist. And then sometimes, if we can do that early enough, we may not need to do anything for the patient. Their tongue will is the best orthodontic appliance that has ever been invented is the tongue if it's working properly. We also look at the Mallampati score. So look at your child, have them open real big. If you can see their uvula hanging down and you can see their tonsils and you can see this dark space all the way from the edge of the tongue to the edge of the tongue, that would be a class 1. If you can see that, they probably don't have anything close to a breathing disorder. If they open and you can still see the uvula, but you don't see nearly as much of the dark area, that would be a class 2. A class 3, then you wouldn't see all of the uvula. You would see very little darkness. And a class 4, you see the back of the tongue and the back of the soft palate, and you don't see any space at all. If your child is a class 2, 3, or 4, they're at risk for a sleep related breathing disorder. So this would be a class 3 here. You can see part of the uvula, but nothing else. So this child is highly has a high propensity for a sleep related breathing disorder. We also assess the tonsils. Now, Dr. Corridor and I are not ENTs, but we can assess the tonsils and we can see if the tonsils are a potential airway issue. And if they are, then we send and get our friendly ENT involved as well. We can also even inject the tonsils with ozone to help shrink the tonsils non-surgically. That's been proven to work pretty well as well. So it just depends on the parents' level of what they're comfortable with. But a lot of ENTs, if the tonsils are swollen, they might not agree with taking them out because they're looking at it from a different perspective. We're looking at it from an airway perspective. Now, we'll tell you this, Dr. Corridor and I both are very, very adamant on doing everything we can to save our body parts. So we're not just an automatic, hey, you need your tonsils out. We work with our patients, we work with the parents, maybe food sensitivity testing, have them tested for mold, maybe eliminate dairy, corn, different things that could be causing inflammation of the tonsils. We're going to try everything conservatively and non surgically before we send that patient in to have surgery to have their tonsils out. And oftentimes we can get those tonsils to go back down. Um, so I talked about this earlier, home observation, even recording their sleep and showing it to your pediatric dentist or your airway dentist. And that's very valuable if we can see ourselves what's happening. Are they mouth breathing? Are they snoring or their sounds when they breathe? Are they grinding their teeth? Are they flailing about? Those are all signs. An ENT can actually scope their airway in their nasal passages and see if their nasal passages are patent. Adenoids are also an airway obstruction. You can see the adenoids right here in this x-ray. So, when it comes to nasal chamber, adenoids, and tonsils, we can make an assessment and work with the patients to try to get these better. But ultimately, if we need to get a specialist involved in that, we use a pediatric ENT. A sleep study is indicated for some kids. Usually, we don't usually do sleep study on children until they're 12 years old. We go by the patients, their parents' observations and what they tell us. So nasal hygiene, we work with nasal hygiene. See, these are all these other things that can be done. It's not just, hey, they need a tongue release or they need their tonsils out. There's a lot of things that we do with the patients. And so we have a complete nasal hygiene protocol that we work with our patients. If we get to the patients young enough, we'll use growth guides. This is one brand called MyoBrace. We use several different brands, whatever's best for that patient. But these growth guides are worn when the patient's sleeping, and they will help the child start breathing better and help coordinate the muscles for proper jaw growth. And so you can see here, this is a patient at 12 months in a growth guide. This was before, had a complete severe underbite, and in 12 months, with a very conservative therapy using a growth guide, we can see that starting to correct. Here's another example. This is the pre-treatment, and the width of the upper jaw was 30, and 11 months down the road, we're starting to, the permanent teeth are erupting. We're getting some growth. And then 9 months in fixed expanders. So a growth guide was used to get the patient to here, and then fixed expanders to get the patient to here. And they're not done yet, but we've gone from 30 millimeter wide arch to 40 in a little over a year. So we use also what we used between here and here was a fixed expander. Those work very well as well. And so if we get an 8-year-old that's really behind in development, a growth guide, like I showed you earlier, might not be the best thing for that child. Time is on our side. We may want to go with a fixed expander. We're not thinking about teeth now. We're just thinking about jaws. If they're just a little bit behind in growth, then even with an 8 or 9-year-old, we might go into a growth guide that they wear when they sleep. But these fixed expanders are very predictable. We also work with myofunctional therapists. Uh, I would say, well, 100% of our airway and craniofacial epigenetic growth patients, we work with a myofunctional therapist with them. Myofunctional therapy basically is physical therapy for the tongue to get the tongue and lips and cheeks to start working in favor of the patient and not being a detriment or working against the patient. People say you can't expand the adult jaw, but we can.
I beg to differ, sir.
I beg to differ. We can actually expand the jaws. And so some of you might be saying, well, what about me? My jaws are small. I had orthodontics 3 times. My teeth are still crowded. Sutures in the jaw don't begin to fuse until the late 60s and early 70s. So if we've even had patients that are in that range that we still expand their jaws and increase their airways. So with adults, we use more of an upper upper and lower removable expanders that can be taken out. But this is what can be done in an adult. Look at those crowded teeth, and look in 6 months how much space that we've gained in 6 months. So we started here and ended here, and then did some more expansion with clear aligners at top of Invisalign, and we ended up with that. This patient breathes much better than they did before expansion. So I want to end, and then we're going to have, then we'll have time for a question and answer. This is a really good video that I can give you the reference for it when we're done, because anybody can go look this video up. But this is really good. It kind of summarizes everything I just talked about. It's about 5 minutes long, but it's really good. I hope you enjoy it. And then we'll have Q&A.
Just a few hundred years ago, the human face was different. It was forward grown. Her wide profile and large dental arches ensured straight teeth and room for her tongue. Most importantly, she had plenty of space behind her upper jaw so she could breathe through her nose with ease. The modern face has changed. From childhood, her dental arches are less developed, crowding her teeth and giving her less space for her tongue, which impacts her airway. Many believe this stems from a number of causes, such as allergies that affect breathing. Another is the poor nutrition and softness of modern diets, causing toddlers to have underdeveloped chewing muscles and smaller dental arches. Because her upper jaw is too far back, she will struggle to breathe normally through her nose. To get more oxygen, she will compensate by opening her mouth to breathe, bringing her lower jaw down and back, creating a downswing of the face. This is how her undergrown upper jaw creates the appearance of buck teeth. She's actually compensating in order to breathe. If not corrected, the problem carries into adulthood. Extractions were documented in the 1600s as a way to treat crowding. Although they are a quick fix, they don't treat the problem of underdeveloped arches and have been implicated in harming the facial profile, making them the subject of much debate even today. In the 1800s, orthodontists in favor of extraction were looking for more effective ways of pulling teeth back. And this is where the story of headgear starts. Not understanding the cause, those orthodontists believed in a myth that in bucktoothed children, the upper jaw was overgrown. They thought that if they restrained its growth with headgear, the lower jaw would catch up and the teeth would line up. Although studies done throughout much of the 1900s have shown otherwise, this myth became a part of the foundation of conventional orthodontics. First, studies have shown that headgear suppresses the growth of both jaws, causing them to grow down and back into the airway, creating a clockwise rotation of the lower third of the face. The industry coined these deformities the headgear effect. The growth changes caused by headgear carry on into adulthood. In order to breathe, she will slouch her head forward to prop open her airway, creating a lifetime of neck and back pain. This is the infamous forward head posture. A simple physics diagram shows that the growth stunting forces of headgear pass right through the skull. One study showed that headgear caused an abnormal rotation of the sphenoid bone, and no study has examined the impact of headgear on the skeletal blood flow and nerve pathways of a growing child, or its long-term effects. Having a healthy airway is crucial to the survival of life, and especially so during sleep. When muscles around the throat relax during sleep, a healthy airway stays open because the tongue is sitting forward and has enough space to be suctioned up against the fully grown palate. With underdeveloped jaws and dental arches, the palate is too small for the fully grown tongue, which is sitting back to begin with. When she sleeps, her tongue does not suction, rather it falls back and cuts off her airway. This is obstructive sleep apnea. Like crooked teeth, it's a modern condition. However, it can reduce life expectancy. Not surprisingly, obstructive sleep apnea is marked by the same traits that describe the headgear effect. Both jaws are grown down and back, creating a clockwise rotation in the lower third of the face. If you have already been exposed to orthodontic treatment that caused the headgear effect, there are ways to reverse what happened. If your child wears a headgear or is exposed to an appliance or practice that retracts structures involving tongue space and the airway, his or her lifelong health may be in danger. There are plenty of alternatives to these practices, so make sure to get multiple opinions. The myth of the overgrown upper jaw that needs to be held back has long since been replaced with science. Science has shown that young children can be buck-toothed naturally, and that the lower jaw catches up over time with a fully developed upper jaw. Essential to this is nutrition, the use of chewing muscles early on in life, and good breathing habits. This means breathing through the nose with the mouth closed and the tongue resting up against the palate. Also, the practice of maxillary expansion has been shown for over a century to correct crooked teeth and improve nasal breathing space. And since 1918, orofacial exercises have been shown to correct mouth breathing habits. There are better ways. Right to Grow is an organization dedicated to ending the practice of orthodontic growth stunting. Please sign our petition online, share this video, and get involved in making the world a safer, healthier place for our children.
All right. Oh, that last video was from Right to Grow, RIGHT TOGROW, Right to Grow. Trying to turn my video back on here. So you can all unmute yourselves if you wish, and I can answer any questions anybody might have. Hopefully that was informative.
I have a couple that I wrote down as you went through.
Okay.
So as far as, I know she said in that video that sometimes orthodontics can be prevented, but if you have a child who does the expansion at a young age, do they later, well, okay, so I have a 7-year-old and a 12-year-old, both likely need expansion.
Yeah.
The 12-year-old, it's going to be really evident if the expansion is working to correct the issues he needs with braces, and he's probably going to finish expansion. And then would he potentially still need to go into braces after that, or does it usually fix kind of the orthodontic issues also?
Usually there's, I would say at least 50% of the time, there's still some need for orthodontic treatment, but it's very minor, because the biggest thing that orthodontics is working against is jaw discrepancy in jaw size. So if you corrected that, there's no guarantee the teeth are all just going to come in perfectly straight. And you have to realize, I mean, you go back and look at movies from the 60s and 70s, a lot of those people had all their teeth, but they weren't quite in a, perfectly aligned, and it wasn't a big a deal back then. So nowadays we're much more aesthetic oriented. So there's probably, we're finding that in at least 50% of our cases, there's still some need for orthodontics, but it's strictly from an alignment to for the bite and aesthetics. It's not, we're not trying to correct severe crowding and all that, because that's already been taken care of. And we do most of our orthodontics with clear aligners, even with teenagers. We don't do it with brackets and wires.
So you do the orthodontics if we go through you. So you're not, that was my other question, was you go to an orthodontist and they just undo everything we did with you.
Yeah, no, we do, when we see a child for expansion, we also do the orthodontics afterwards.
Okay. And does the expansion ever fall under, I know there's a medical side to y'all's practice and a dental orthodontic side of the practice. Does the airway expansion fall under medical ever, or is it always dental?
Well, it can, if there is in general, when we're talking about adult patients and we're using epigenetic growth appliances, those are more on the medical side. Most people's dental insurance will have a coverage for like interceptive orthodontics, like expansion and then full orthodontics. But there's also depending on the situation, for instance, if a child is, and we've had some young children, I'm thinking of one in particular that was, I think when he was 5 or 6, he actually went and had a sleep test at an overnight lab and was diagnosed with obstructive sleep apnea. So once that happened and they had an official diagnosis, then that's when medical kicks in. most kids aren't going to go and have an in-lab sleep test for 2 nights in a row. And so our sleep diagnosis is from what our parents tell us. So the majority for kids, majority of their insurance coverage is on the dental side, not the medical side, when it comes to jaw growth and when it comes to orthodontics. Now, having said that, every insurance company is a little bit different. I know for those patients of ours that are in the what do you call, like, Christian.
That's what most of us, or
Yeah.
several on the call
Yeah.
have.
We write a letter of medical necessity for those. We do that for all of our patients, but those tend to respond very positively
Okay,
for that.
okay, that's helpful. Great.
Hi, Dr. Stewart.
Hi, Stacy.
Hi. Okay, I have a question regarding my 6-year-old.
Yeah.
He had a lot of the symptoms that were listed for sleep disordered breathing, except he's not a snorer, but ever since he was little, I'd find him in like a sweat at night. And his mouth would always be closed, but he'd just be covered in sweat. So I knew there was an issue early on. We have him in his first expander, or expander appliance. He's a month in. He has pretty severe ADHD, I would say. And I got my kids in the background. But my question is, how long have you seen changes in the ADHD behavior? And if so, how long roughly? We're only a month into our first appliance, and he has a frostbite as well. So we may have like a longer road ahead of us. I'm not sure, but yeah, I was just curious to know about that because it affects our daily life. And
Right.
yeah, I want his sleep. I want his sleep to improve and that other symptom.
It should improve. And one thing that I would tell you is that a lot of orthodontics will expand with one expander. They kind of have a protocol. They'll expand, 4 or 5 millimeters, and then they'll just hold them until they're ready for braces. We don't do that. We keep expanding. Remember that 24 plus the age. So if if he's not at least 30, I mean, at the very least 30 millimeters between his molars, then he's under expanded. But if he just started, he probably is. I would say, to answer your question, and I'll get Dr. Corridor's opinion on this too. I would think that because when you expand the maxilla, you're also opening the nasal passages. It's the same, the roof of the mouth is the floor of the nasal cavity. So he should start breathing better, like within, a couple of months, 3 months. I would say within 6 months, you should see a difference, a significant difference. What do you think, Dr. C?
As far as change, well, one thing I was going to comment on is, we like to think of ourselves here kind of as the hub, like Dr. Stewart had said, and monitoring through different development stages. Because a lot of times you can have a child as early as 6 years old, goes through expansion, and a lot of practices will say, okay, you're done, and then not see you for another 5 years. But what we're finding is going to happen a lot of times is this child may be introduced to something that wasn't there before. For example, an allergy or a food sensitivity that's causing some of the mouth breathing to occur. And if that's not being monitored, some of that expansion that you gained early on, you can have a relapse because now the tongue isn't functioning. So it's a matter of looking at all these different moving parts and making sure that they're intact, that this patient is continuing to nasal breathe and they're not mouth breathing. They haven't regressed to a bad dysfunction or a bad habit. We're finding more and more here in Texas, for example, mold toxicity. You move into a new home and now there's mold toxicity at that home. And if the patient isn't being monitored, as a parent, you may not know that this child is struggling. So it's not a matter of like, here's one treatment, then you're done. It's more about monitoring, just like you would continue to go to your dentist and get, cleanings once a year, twice a year, but just making sure that somebody, whether it's your pediatric dentist, whether it's us, somebody that's still monitoring those development years and making sure that this child's developing correctly. Does that make sense?
Yes, that does. Thank you, guys.
Have you had your son's child has his nasal passages, tonsils? Has that all been checked out as well?
Well, so just FYI, my phone might die.
Okay.
But we have been going to Beyond Pediatric, and I don't know if they did an oral evaluation, but I don't know what they do in regards to tonsils.
Okay.
And
Well,
yeah.
that's a they're a good they're a very good practice. So
Okay.
they've probably assessed his tongue and lip ties and all that.
Yeah, and we have had his tongue done twice and his lip. So they said he has some scar tissue underneath still on his tongue, but they said some homeopathic remedy. I can't remember it, but they said that can help get rid of the scar tissue. And so, yeah, maybe they did look at his tonsils. I just don't remember them commenting on it.
Has he had myofunctional therapy?
No, he has not actually. No.
Okay, so I won't do a tongue release unless the patient's had myofunctional. Now, I say that if it's a toddler, Dr. But if they're over 4 or 5 years old, they have to do myofunctional therapy prior to and after the tongue release, and we see phenomenal results. So you might want to talk to them about him doing some myofunctional therapy because that's help his expansion. Is his expansion device fixed or is it removable?
It's fixed.
Okay, so probably why he's in the expansion device, you wouldn't do myofunctional therapy, but when they take it out, it's great for him to move into myofunctional therapy because that will then train the tongue to just continue on to what the expander has been doing.
Okay. Okay. Thank you very much, you guys.
You're welcome. Anybody else?
I have a few questions.
Okay.
I have an 8-year-old daughter who she's got plenty of space between the teeth, but her teeth match perfectly on top of each other. So we've just established with a holistic airway minded pediatric dentist in Fort Worth, and she's recommending orthodontic to be looked at. And I'm just hesitant to go into equipment right away, but I don't know that she doesn't need space necessarily, but she does have a forward tongue, they said, as well. And she was tongue and lip tied and released as an infant. But is that something that would likely need the expansion that you're talking about?
Well, when you say their spaces, but the teeth are on top of it, are you saying the upper and lower teeth are like this?
Yes. Yes.
Okay, so she is her upper jaw is not developed forward. That's the issue with her. Width-wise, it may be okay, but it may need more development from front to back. And so that can be accomplished in a few different. How old is she?
8.
8. So she might be a good candidate for a growth guide, to wear while she sleeps. In an adult, it's really one of the most difficult things is to get forward growth, but in a child, it's pretty easy. So what a child like yours really needs to have a what we call a Sassoon tracing. It basically is a cephalometric X-ray, and then we trace and we can see where the growth deficiency is, and then we can pinpoint a type of therapy that will actually correct that part of the puzzle. Because it sounds like she may have good width, she just doesn't have forward growth. But one place to start is myofunctional therapy. I would get with them. Where do you live?
We're in Alito, so West Fort Worth. And I got 2 recommendations for myofunctional therapy from the dentist, but she said to also, she referred an orthodontist, but I don't want to go to someone who's just immediately going to put equipment in her mouth.
Yeah.
Versus looking at the expansion part too.
She may not need that. Was one of the referrals for myofunctional therapy, was it Marvel or Marvel Myo?
It's Mary Brezick and Perry myofunctional therapy were the 2.
Yeah. We do a lot of work with Caitlin Spencer, and she's in Fort Worth.
Okay.
She's remote. Yeah. It's her company's Marvel Myo. These other ones may be fine. I don't know. I just don't know of them. I would get a good myofunctional therapy program going. Because if you get the tongue working properly, it could help advancing that maxilla. But it sounds to me like it's what we call an AP growth issue, front to back, and those are a little bit, like I said, as a patient gets older, those are harder to correct. So your child might be in that right in that area where, of time where, some kind of appliance therapy just to jump that gap and get that upper jaw growing forward might be, needed at this point.
So
So
do like it might be beneficial to do the myofunctional plus going to see you or someone
yeah,
to have
yeah,
an
I don't
appliance.
think I wouldn't at, at her age, it wouldn't, she didn't need braces, orthodontic treatment like that. Um, she needs craniofacial jaw development.
Hmm.
And once that's done, the braces may not ever be needed, or they'll just be minimal.
Okay, that's good to hear. There's a lot of girls in her grade, they're showing up with braces,
Yeah.
and so she's like, "Am I getting braces?" She thinks it's fun. And I'm like, "We don't want to get braces if we don't have to get braces."
Yeah, it's not braces are for teeth. This is not a tooth issue at this age. It's a
Right.
jaw development issue.
If we just got established and have all of these x-rays minus that one that is there like sharing that can be done of that to minimize
Yeah.
re
Yeah. As
cost of?
a matter of fact, whenever we see, this is something that is just really very frustrating in our profession, is sharing of records. When we see a new patient, we have a business card USB 16 gig. It looks like a business card with our logo on it. We put all of their records in that, and we give it to the patient so that if they decide they want to go get a second opinion or whatever, they've got everything with them. So yes, by law, any practice has, once you request records, they have 30 days to get those records to you or to whoever you've um, requested them to be sent to.
Okay. Last question, like, if we were to see you, how often are these appointments needed as we're driving an hour away?
Yeah,
Like,
we have a lot of patients that drive, you know, 2, 3, 4. We have some that actually fly in. We've got one family that flies in from Nashville. So once we go into if it's a fixed appliance or if it's a removable appliance, we generally, for patients that live really far away, it's about 6 to 8 weeks.
okay. All right. Thank you.
Yeah, you're welcome.
This is super helpful.
Okay,
It's
good.
like very overwhelming to hear when it's something that I'm just not knowledgeable about at all.
Yeah,
And it can just feel overwhelming for someone who's never, I didn't have braces or anything. So I just
right.
am, so thank you for all
It,
of this.
it is overwhelming, and that's why we like to take that burden off and just say, look, here's where everything is. Here's the game plan. Like it's like a recipe. You know, you warm up the vegetables, and while they're cooking, you do this, and then you mix this in and that in, and you end up with a beautiful dish at the end. It's not just throw everything in a microwave and hit go. And so that's what we really take pride in doing, is helping our patients' parents understand all of the factors that are involved in if and when and what order things should be done in a logical manner,
Thank
because
you.
it can be overwhelming.
Individualized.
And it's individual for every single patient.
Hmm. Thanks so much.
You're welcome.
Dr. Stewart, this is Cameron.
Hi.
Thank you so much. It was an incredible presentation, such great information. So my one question is, because I know you guys are probably on a time schedule, is there a way to share this presentation with other people who wanted to be on but couldn't do it today?
Sure. Did we record this?
It said recording when we
I
started.
think, yeah, it should have recorded. Yeah, it's recording. Yes.
Okay,
Yeah,
awesome.
well, what I'll
So-
do is once we get we upload these to the cloud, it just does automatically. I'll have Jessica send you the recording, and you can play it for whoever you want to.
That is wonderful. Thank you so much for taking the time. It was great information. I've got other questions about adults, but I'll wait until we go over Luke's information with you guys.
Okay.
I have
Okay.
one more kid question. I think it's quick.
Okay.
My 16-year-old has already had braces.
Mhm.
I know she needs expansion. After I saw you for my appointment, I came home and measured all my kids, and I know they all need it, and I know I need it. So I just need to actually get my act together and come back out there. But I can't remember what her number was, but it's very narrow. And several of those pictures you showed at the beginning, she's got that kind of backwards or back pressed jaw. Like I see her rolling shoulders forward. And I often ask her when she's eating, I'm like, are you congested? Why are you breathing like that while you're eating? And she was like, I don't know. So there's a lot of indication that there's an airway issue. But again, she's already had all the braces. So if we did need to go in and do expansion with more than the nighttime situation, would she likely need to redo orthodontics after she did expansion, or does it kind of flow with the already corrected teeth position?
It can. I would say this because I have two daughters, and I know that if they end up with just a little bit of gapping or something, they're going to want to have that straightened. So I think most likely you would probably need orthodontics again. It wouldn't necessarily be full 2 years of braces and wires or anything like that. It would be minor, but you know the teeth will go along for the ride. But it's a bit unpredictable exactly where they'll end up. Usually they end up pretty cleose to where they need to be.
And could that be corrected with Invisalign or something where she's not back in braces? Okay.
Yeah, we use clear aligners for
Majority,
90% of our 85, at least 85% of our orthodontics.
Okay. Great.
Especially for teenagers. The only times we use wires and brackets anymore is for, if for these rare occasions we have kids with just really severe growth issues and we need to have some anchorage. And so, but they're usually in their, younger than that. But clear aligners they're the best. Actually, they're much better than brackets and wires anyway.
Okay.
Yeah.
Great. Okay. Thank you so much for your time. I appreciate it.
You're more than welcome.
Okay.
And yes, we do need to get going. We've got a couple of patients that have been seated and more. So it's been our pleasure.
Thank you.
You guys, if you guys ever want to do this again, just let us know.
Okay,
Thank you so
much.
much.
Okay.
Yeah, thank you
Bye.
both.